So from our company, Vital Solution, we do contract and work in rural parts of the country. And so when I got out of the Navy, I was very interested in what is the mission. What do I want to do as a cardiologist? And has to be a mission. And so the mission is dealing with some of the healthcare disparities that we see in rural America. And this has been incredibly fulfilling, not only for me, but for 115 interventional cardiologists that are utilizing this method either full time or part time. So rural America does have its own set of unique issues. We tend to see very high rates of cardiovascular disease, 40% higher in rural America compared with those living in the urban parts of the countries. Multiple different articles have come out that summarize and show some of these differences and disparities. But in addition to higher rates of cardiovascular disease, we see worse outcomes. We see those that are living in rural parts of the country, they don't live as long. They have less access to care. They have lower rates of cardiac cath, stenting, and bypass surgery when you compare those to their cohorts in urban parts of the country. And because of these limited access to resources, like I mentioned before, we do see poor outcomes and lower life expectancy. Estimated 60 million people living in rural parts of the country right now. And as these disparities continue to grow, it's going to need more and more attention. Next slide, please. A recent study that came out in the Journal of American College of Cardiology last summer was a fantastic call to arms, so to speak. This was a group out of Boston, one of the Harvard facilities, that compiled a bunch of data and really made a lot of us stand up and just kind of scratch our heads. We saw that 86.2% of all the counties in rural America don't have a single cardiologist. 86 of those that are considered rural counties. It was 50% of the total number of counties in the United States. And in those that didn't have a cardiologist, the average amount of travel was 87.1 miles. So even if you're having a heart attack and you have to travel 87 miles, the time, as you can imagine, is heroic. And that's assuming that you're in parts of the country that have good weather without logistical capabilities and transport. Whereas a lot of these facilities are either in the mountains or rural parts of the country that have to deal with weather. 87.1 miles might as well be around the world for a lot of these communities. So it's not surprising that we see worse outcomes. I mentioned before, but this study also showed that there was a significant higher prevalence of coronary artery disease, and we can speculate as to why that's the case. But from what I've seen and what I've gleaned and gathered over the last several years is that access to specialty care is difficult, but access to primary care and establishing a good relationship with primary care providers is also equally as difficult. And if you're not able to address some of the risk factors for cardiovascular disease early, such as hypertension, hypercholesterolemia, diabetes, lifestyles, tobacco, etc., then we tend to see higher prevalence of coronary artery disease. So primary care access is paramount. And because of all this, we tend to see that these patients have, on average, 1 year less lifespan than their urban matched cohorts. So really the first step in dealing with some of the crises and some of these horrifying statistics is awareness and understanding of the issues and then coming up with creative solutions to combat them. So next slide, please. Rural facilities have issues with recruiting. Some of these facilities, some of these locations are remote. There's a lot of reasons why, as a new or recently trained physician, that you may not want to go travel or may not want to live in a rural part of the country. So recruiting and retaining physicians is difficult, but this also applies to the rest of the healthcare team, which I think often gets overlooked. Nurses, highly qualified technicians, and administrators, they also have a hard time recruiting and retaining. And as this team will tell you, physician is fantastic. However, without the entire team to support them, without the administrators to put these teams together, we're worthless, flat out worthless. So we have to look at recruiting and retaining across the spectrum, not just within the medical communities and the medical staff. Facilities are often plagued with a lot of skepticism, and if you look at what's happened in rural parts of the country over the last 15 to 20 years, it's not too surprising. Look at the opioid pandemic and how a lot of these rural communities were targeted. It's atrocious. And because of that, we see a lot of skepticism. We see a lot of patients that look down upon their health care that's available to them in their communities. We see poor reviews. If you ever want to review these, just go to Google a hospital in rural parts of the country and read the reviews on Yahoo or on Google, and you see some of the concerns. Because of that, we really have a lot to overcome with restoring and building the reputations for these facilities. Community hospitals suffer financially. When you look at how they've done fiscally, we see that it's not good. A lot of these facilities have very low private payer and higher CMS um, um, percentages. We see that they're closing at higher rates than their urban counterparts. Matter of fact, from 13 to 17, 64 rural hospitals closed, which was a rate nearly double that the previous 5 years, which is significantly higher than those in urban parts of the country. So we have fiscal responsibilities as well that are hard to overcome. Next slide, please. So, one of the things that drew me to this organization was um, which when I first started was a company called CardioSolution, which is now rebranded to VitalSolution. But VitalSolution is very fascinating. It was founded by a friend and coworker of mine, Lou Vadlamani. He started it back in 2011 when he was here working in the same area where I'm living right now, which is in the DC metro area. I live in Bethesda. He lived in Northern Virginia, which is a saturated community. It's a beautiful place to live. Tons of culture, tons of things to do. The school systems are superior to a vast majority of areas. Really a great place to raise a family. However, not always a great area to work because of the saturated market. Facilities and interventional cardiologists are tripping over themselves in many places. So Lou started. He was contacted by several different facilities needing assistance, and this idea kind of grew with him. He had then developed a partnership with healthcare administrator, and CardioSolution was born. Since then, we've continued to grow pretty dramatically. We were purchased with a large acquisition with what's now called Ingenivis Health about 3.5 years ago, which has really spurred on um, uh, funding and growth potential options. We now provide strategic solutions for our rural healthcare partners that is not only with physician staffing, but also nurses, technicians, and healthcare administrators. Our cardiologist model is 24/7, 365 coverage in a facility with a 7 on, 7 off model, which means that when I was working in northeastern Pennsylvania, there were two of us, myself and my partner, who would go in, we'd cover for a week, we would then have a handoff, and then the other person would come in and we'd go home. And in theory, we would then have 7 days to go home, spend with our families, recoup, readjust, and be well rested so that when we go back the following week, we have less issues with burnout, less issues with fatigue, and we can really devote our time to patient care. It's a great way to separate work-life balance. The other beautiful thing about this is our cardiologists can live where they want to live and work where they're needed. I had options of working for private practice, working for government run hospitals here in the DC area. But when I found out a little bit about CardioSolution, now VitalSolution, it was very appealing. And I've been with them now almost 4 years. And it's just really been a fantastic experience. Next slide, please. We've now grown. We're now covering 43 different sites over 24 different states. Actually, this has been outdated. We now have a site in Hawaii and soon have one in Arkansas as well. So we continue to grow at a pretty dramatic rate. We initially provided only interventional cardiology services. This has since grown based on a need. And so we do offer general cardiology as well. And then last year, we launched an anesthesia service line. That's when we rebranded to VitalSolution. So we offer general anesthesia, CRNA roles as well. We've had cath lab nursing techs, and then more importantly, our service line managers and directors that can go in and help run these complex service lines that are sort of their own unique animals, so to speak. So the most important thing that we can do as an organization is sit down with the executives in these facilities, sit down with their C-suite, and truly identify what their needs are. We are not a one trick pony. We need to sit down and understand exactly what they need. We need to um, come up with a good plan to meet their needs, and then we need to actually implement the plan. And that may be recruiting and then retaining physicians, nurses, techs, administrators. The facility, like Christy mentioned earlier, may come in and they might have this vision that they want to start a open heart program, or they might want to start a cath lab. They want to cover heart attack potentials 24/7. They have this vision, they just don't know how to do it. So we work with the facilities. A lot of times we'll bring in Corazon to consult as well, and I'll kind of get to that in a few minutes about really how nice that touch is. But we start from the ground up. We work with medical architects to help design their cath lab. We can help with equipment selection and acquisition. We can help them develop their standard operating procedures and implement the plan. Next. It's not just enough though to come up with putting a warm body in a seat. We really have to encourage and incentivize the right approach. And so, our physicians, when we go in and we start a program, we actually incentivize and we provide quality and team building bonuses to those providers. So we want to make sure that they're doing outreach, that doing public relations, they're working with PR at the hospital, they're going out and speaking to community events, holidays, Memorial Day, going and speaking with their emergency medical systems, doing presentations and talks, so that the community realizes that there is a change. There is this new invigorated response to making sure that that community receives the care that they deserve. We have a medical leadership team. I have myself as the chief medical officer, and I have 4 very hardworking regional medical officers to ensure that there is quality, and that to make sure that these facilities are receiving updated protocols, that the standards of care are being met and hopefully exceeded, to make sure that the right things are being incentivized. We developed a quality program at a very large reduction in profit to help make sure that our team is motivated in doing the right things. We have constant communication. Our 360, which is our quality program, is a proactive tool designed to get real time feedback, relying on the traditional patient surveys that are, I'm not going to mention any names, but are very lengthy, very cumbersome, and have about a 5 to 10% completion rate. Our program is very simple. It's very straightforward, utilizing surveys. We can get real-time feedback. We can make adjustments on the fly and make sure that if there are issues that we address them very early on. And this has been really amazing. We've developed a very unique medical community amongst our providers. Like I mentioned before, right now we have, I believe, 60 full-time physicians and a little over 50, if at 55 part-time physicians that come in and fill in as needed. But when you're working and you're an N of one and you have a partner that you might see for an hour or two on handoff once a week, it's nice to have a community that you can fall back upon. So we've actually developed regular quarterly cath conferences. We have town hall meetings and have been working with some industry providers to develop or to utilize their software for physician communication, so that we have real-time feedback. So if I'm doing a case and I want to know, what would my colleagues think? If I'm in a large facility, I would just have the control room page them, have them come down, take a look at the films, and we can decide. We don't have that when we're a solo practitioner. So utilizing technology, we have HIPAA secure platforms, one in particular called Coltrane, which was an app developed by a rural cardiologist in Washington State and a CT surgeon in Kansas that provides real-time real-time communication in a HIPAA secure platform. We can actually show cath films and have open and real-time dialogue, which has really just been a game changer for our model. So, I started working with VitalSolution in a facility in northeastern Pennsylvania hospital It's very dear to me, called Wayne Memorial. This is in northeastern Pennsylvania, about 45 minutes northeast of Scranton. So it's just right under the New York border, in a very nice area. They decided in 2016 that they wanted to have an open heart program because they were seeing many patients that just weren't making it to the closest hospital, which is in Scranton, about 45 minutes away. So they came up with the idea, and they actually started the program themselves. They hired a single cardiologist that was a very hardworking individual, worked very well for a short period of time. And then because he was the only one, he had burned out. And so then they contracted with us. And since then, we've been providing full-time coverage with them since 2018. And with that time, we've had no missed days for illness. We've had constant coverage. But Memorial was also partnered with Corazon because of the state requirement for oversight. And so that was my first exposure to Corazon, and I got to see how they helped Wayne Memorial start their program. I got to see the protocols that they had helped institute, and I was pretty impressed with what they had done and what they continue to do. We pushed for accreditation at the facility for a couple of reasons. One, the facility was eager to improve, but they needed some guidance, and that's exactly what we were able to gain with Corazon. Next slide, please. So in 2022, they got their first chest pain center accreditation. That was renewed a few months ago. I was still there at that time, and they continued to do much better. But we saw several things significantly improve. And the first and the most important thing is communication. By forming and establishing a solidified chest pain committee, that brings all the players to the table, literally. We have hospital administrators, there are cardiologists, interventionalists, emergency room physicians, nursing, and techs that are all part of this, that all have an equal seat at the table. And because of that open communication, we've been able to really fine tune what areas can be improved, and we come up with creative solutions to do those. We've had significantly improved door to balloon times. The average time when I was last there was less than 55 minutes, with the national standard goal being less than 90 minutes. So they really have done an amazing time delivering high quality care. And because of that, we have significant improvements in patient outcomes, and volume is continuing to increase as well. So it has been a beautiful union of how Corazon and VitalSolution have worked well together to really improve and save hundreds, if not thousands, of lives in one particular community. It's been a really heartwarming and heart-saving endeavor.